our moderator, Dr. Jitendra. His topic is combination therapy for prevention the progression of myopia. Please.
Thank you. Thank you. It's an honor to present at Asia Pacific Myopia Society Symposium. So when we have mono single therapy treatments and when patients don't respond to that, we obviously switch over to some of the therapies which are already available, and we try to make some combination of that. And in the beginning, we do have some thought process whether this will work or this would not work. So that is how we started using atropine with defocus lenses few years back. Now we all know this basic premise as to how and why myopia progresses. So one of the theories is that with near focus there is peripheral defocus, and another is that there is less outdoor timings. And we will have a separate lecture by Dr. Pawan on which one is a bigger culprit, whether it is outdoor timing or it is near work. So this was where bulk of the atropine evidence started, and these were, as Dr. Jason already presented, these were follow-up studies of how atropine works and how glasses work. And there's interesting, this is quite interesting. This was way back in 2007 when Earl Smith published his first paper on relative peripheral hyperopic defocus and how it can alter the central refractive development in infant macaque monkeys. And gradually we had origin of glasses, defocus glasses from Hoya, from Essilor and different companies. And these glasses do claim that they work independently on the peripheral defocus areas, and basically what they do is they alter the hyperopic defocus to the myopic defocus, and thereby they prevent the growth of the eyeball. So basically all of this what we are talking about is axial myopia. Both atropine and glasses would be working on axial length, and they would reduce the size of the, or rather they would alter the progression of eye size. So first of all, when we start with combination therapies, we are first of all worried whether it is safe enough, to start both atropine and glasses. So there were few studies where they found out. So one of the first studies was published in 2022, where they actually toyed with the idea whether it was possible to use DIMS lenses with low concentration atropine eye drops. There was a follow-up article in PLOS 1 in 2023 where they showed that there were good results with combination therapy in European population. We did our own work, and this was published last year, and where we showed that as an adjunct, glasses do work better with atropine, but all these patients did not have combination therapy as a primary therapy. All these patients were atropine non-responders who continued using atropine, and glasses were added as an adjunct later. So the theory is quite simple. Both the things are working at different levels, so they should potentially be helpful, be more symbiotic, because atropine is working at a different level, glasses are working at a optical defocus. So what is the efficacy? This is a good article published in 2023 where they showed that DIMS and atropine offers efficacious intervention, and it slows down the myopic axial elongation. And when you combine these two treatments, it becomes more effective compared to a monotherapy. And this was our observation, which we did present 2 years back at AIOS. And we found that, so you can see that there is something which is pre-atropine progression. Pre-DIMS progression is when atropine has already been given, and despite giving atropine, they were still progressing. And then there is post-glass introduction. So our experience is good with all the companies. Both right now we have used two of the important companies which are making these glasses. Both the companies have come up with their own versions. Both of them work well. This is especially for the non-responders. We do have worked, but we don't have enough follow-up right now to talk about combination therapy as a primary therapy. But both the therapies work, at least in non-responders to this point of time. And the advantage is that, since they are working at a different level, the effect has to be symbiotic. Together is definitely better. And there has been another article which came up on myopia prevention and control, which also concluded that if you use combination therapies in children who are either not responding to one therapy or they are progressing far beyond, like if they are progressing one diopter every year, or if you see that axial growth is quite high, you can introduce both the therapies together at a single go. So indications, we started calling them super progressors, whether it should be primary therapy in super progressors or not. So definitely we can go for that. Atropine non-responders, definitely a choice. In our case, we do start with glasses if the children are very young and we know that there can be some issues with pharmacological intervention, or we suspect that there will be a compliance issue. We do tell parents that they can start with glasses, and maybe if they don't respond completely with glasses, we can add on atropine in pre-pubertal age. Pre-myopes, yes, glasses can be used, and same is with atropine. So that was regarding the combination therapy of glasses and atropine. Thank you so much.